Yeah, Ali, thank you for including me in this roundtable. We work on KCNT1 channels for quite some time, but more or less we're cooking in our own juice, so to say. And it's really great to be part of this community, and particularly also, sharing the tools that we have developed with each of you who, wants to work with us on this. So my lab is not only focusing on KCNT1, but we're also working on HCN1, KV7, and SCN2A, particularly with patient-derived mouse models, because I'm also a medical doctor and somehow dedicated my life to rare diseases, starting with lysosomal storage disorders, cardiac arrhythmias, channelopathies, and now focusing on really um, trying to understand how these rare ion channel mutations have shared or separate distinct disease mechanism. This is for KCNT1, we did develop a high throughput thallium flux assay screen. These are two compounds, the two best compounds that came out of the screen, pimozid and carvedilol, with IC50 values below 1 micromolar on PET hex cells in patch clamp experiments. And we selected the two mutation hotspots in KCNT1 to generate also patient-derived mouse models. And we selected them based on the patients, but also based on the gain of function of the channel measured here in oocytes. I've just named them now RQ and IN mutations, so that we have like a gradient increase in KCNT1 gain of function also in the mouse model, like RQ followed by IN mutation and then homozygous RQ mutation. So we can kind of increase, we have two mutations, but we have overall three models with graded increase in KCNT1 gain of function. Just showing you a heterozygous IN mutation. This is how the seizures look like. The mice develop spontaneous generalized tonic-clonic seizures. We made the mice on a CD1 background because these are CD1 mothers are really good mothers with large litters because we aimed at drug testing, and that's why we wanted to have big litters. And often with Black 6 mice is a problem that you have small litters and high infant mortality. Both of our lines show typical epilepsy markers like upregulation of GFAP indicating astrogliosis, changes in perineuronal net, expression here in the dentate gyrus, WFA staining, and also upregulation of MPY. So we think these are spontaneous epilepsy models. They don't have an increased mortality, so they breed well. So they are really, in my view, useful models to test compounds. We also looked, because I think later cognitive problems will also be a topic, looking not only at the seizures, but particularly also at the inter-icle activity. So these are power spectra from the three lines during REM sleep, slow wave sleep, wakefulness. We can already see that there are baseline shifts and presumably lower theta or beta or gamma oscillations in both of these animal models. They're very similar in this respect. And when you quantify it, so this is really, you can see the number of animals not yet that large. You can see that particularly theta oscillations are strongly reduced in the RQ homozygous model, and are kind of, there's a trend in the IN model. We did a drug test, a trial with carvedilol in animals aged at least 9 weeks, because they are larger and it's easier to work with them, also with telemetry implants. But what you can see here, this is a take-home message. There's no change in intake activity when we give carvedilol via osmotic mini pumps, nor I can tell you was there any change in the epileptic activity. So carvedilol in adult animals seems to not have a disease-modifying effect, neither on the frequency of seizures nor on the inter-icle activity, which is important for cognition in particular. We did then switch to an early treatment because, what can we achieve with carvedilol if we already start very early. So we started first in wild-type animals to see what drug concentrations, whether we would do clinically relevant drug concentrations in the mice calculated according to their body surface, and which we did. And then we basically did a drug trial starting at P7, then doing telemetry implantations around 3-4 weeks of age, and then recording at least a baseline of 7 days, and then taking blood and measuring the values. So I don't have many results, but one result is when you look at the power spectrum, when you take the aperiodic exponent of the aperiodic component as a proxy, potential proxy of EI balance, when you compare blue and black. So this is wild type, this is carvedilol treated animals, these are vehicle treated animals. You can see that presumably there's a normalization of excitation inhibition balance in the network. It's really preliminary, but thought for the purpose of this meeting, you might be interested to see this. And when we looked at seizure-free days of these animals during the recording period of 7 days, all the vehicle-treated animals had seizures, and I think only 3 out of 7 carvedilol-treated animals had seizures. I have to say now we are waiting for the approval by the Animal Ethics Committee to start a trial where we will not inject. This were like subcutaneous or IP injections for the first 2 weeks, but we will use slow release subcutaneous pellets in order to also reduce the stress of the animals, because this, of course, also interferes with the drug response and the effectiveness of the treatment. So that's all I have to present today. Hope next meeting I can present you some more data showing in both. This is the IN model, and we are now treating also then the RQ model just to see what can we achieve with clinically relevant doses of carvedilol and also pimozid. Thanks. Yeah, I can agree with David that I wouldn't try quinidine, at least in our patch clamp experiments. Also in the screening, quinidine was really marginally effective on the clone channel and hex cells, but carvedilol and also pimozid were quite good. I mean, half below 1 micromolar is not so bad in my view. And in terms of the treatment, I think it's pretty clear to me that when we're treating adult animals corresponding to maybe 20, 25, 30-year-old humans, that the network has changed in a way that we don't affect really much when we block KCNT1. We will try genetically blocking it by promoter blocking with DCAS9 system. We'll see whether this will bring something. But I think the early treatment group that we did, it's a pilot study. I have to say, it's really preliminary, but based on the results so far, treatment starting at second postnatal week, which corresponds to still in utero treatment in humans, look pretty convincing so far. I mean, still we have no behavioral data, and we do not have any of the biomarkers analyzed yet. But I think the next study with more animals, at least 20 animals per group, and 2 different models with different levels of KCNT1 gain of function will show more. And I hope that about half a year from now that we will know the result. And then, of course, it will be important to also start treatment later. And since we switched from injections or from subcutaneous pellet placement with slow release formulation to food, it will also be interesting to see when we do this early treatment, whether then later, after, for example, puberty, we still need to treat, or whether, when inhibition is matured, we can then stop medication and still have no epilepsy or cognitive impairments. But there are clearly so we are not only focusing on the seizures, we are, I think, intact activity. I showed you the cortical changes in oscillations. We're also looking at hippocampal cortical oscillations with depth recording silicon probes. And so I have to confirm that I'm speaking English. So obviously I have an accent here. Sometimes people think I'm Irish. I don't know why. Uh, yeah, so I think we also have data on acute injection and effects on depth recordings, which are being analyzed at the moment. So it's a lot going on, but not many definitive answers at the moment.